Next, we will have Dr. Natasha Petry from from NDSU right here.
All right, thank you. It's great to be here today, hear all sorts of great stuff going on around the state. And I am here today with Dr. Tamara Ruggles, and we're going to talk about our study, which is about pharmacogenomic testing, and specifically in the long-term care environment. So in the world of pharmacogenomics, we have a lot of alphabet soup, but a few key abbreviations to keep in mind. Today, GDI would be gene-drug interactions, LTC for long-term care, and sometimes, since pharmacogenomics is a long word, we will just say PGX. So a little bit of background is that adverse drug reactions, probably not surprising to anyone in this room, are a very big deal in the United States and a leading cause of death and a main cause of many visits to the emergency department. And specifically, when we look at seniors, elderly people are on many medications a lot of the time, not all of them, but we can look at hospitalizations due to that, polypharmacy, drug-drug interactions, and then in some cases, drug-gene interactions. And so when we look at polypharmacy, we had the cutoff of 5 medications or more, and it's pretty standard, which we use for our study. Pharmacogenomics then is, if you break it down, it's essentially pharmacy and genetics. So taking a look at how genetics can affect medication response. And this may be with metabolism. So you might have a patient who's a faster or slower metabolizer of certain medications. Sometimes it's with transport of the medications, sometimes with receptors. A lot of the strong evidence that we have right now in pharmacogenomics really is kind of in the metabolizer and a little bit in the transporter state. And we use pharmacogenomics in many ways, but I like to kind of bucket it in like efficacy and safety. So with pharmacogenomics, we're hoping to find medications that will work or are more likely to work for patients and less likely to cause side effects or in some cases toxicities. And there are some examples where those toxicities can result in death. And so it's very helpful, obviously, to have this ahead of time in a preventive manner, but reactively also can be very insightful, especially if you're asking the right questions of the patients. Now, one of the promises of precision medicine, right, is like, yes, we're gonna like tailor this exactly to you. And there's many components of precision medicine, with pharmacogenomics being just one piece of that, and recognizing that a lot of things play a role in medication response. So age, kidney function, our environment, the list goes on and on. So recognizing, pharmacogenetics is just one piece of this. And we've been gaining evidence in the field of pharmacogenomics for many years now. And so there are some medications that have very strong evidence as far as their association with pharmacogenomics. There's other medications where we know that there's an association, but we don't have enough evidence to say if you're a rapid metabolizer of this gene, then you shouldn't be on this medication, for example. So there's some in the middle where we know there's an effect, not quite sure what to do with that effect. Then there's other medications where we just don't even haven't even begun to scratch the surface with genetics yet. So when we think about doing a study for pharmacogenomics, it's really limited to those medications where we have pharmacogenetic guidelines. And there's a group called CPIC, the Clinical Pharmacogenomics Implementation Consortium, or a few other groups, or else, of course, the FDA has label guidelines for pharmacogenomics in a few cases. So there's over 100 medications that CPIC has guidelines for. But some medications where we think are very commonly used, unfortunately, we don't have evidence-based guidelines yet. For example, a lot of our diabetes medications. For some hypertension, there's a handful of medications, but not generally the very commonly used ones. However, when we look at the long-term care sort of population, many of the medications that we have strong evidence for, they're likely to be on one of those medications. So a statin for cholesterol, pain medication, a PPI, proton pump inhibitor, anxiety and depression medication. So when we were looking to design our study, it made sense to look to this population, but especially because it's a very understudied group in pharmacogenomics. And when we were looking for literature, there's just really not a lot out there. And so we thought we could really add to the literature if we focus on pharmacogenomics in the long-term care setting. And so we wanted to look at pharmacogenomics, again, especially in the long-term care setting, to see about can we reduce these side effects, adverse reactions happening, and specifically looking at the drug-gene interactions that we find. Can we optimize medication regimens? Can we decrease overall medication use and help with polypharmacy? And can we improve patient quality of life, specifically looking at pain and depression scores? So we wanted to look at the drug-gene interactions, and we looked at one long-term care site in Bismarck, North Dakota, where Dr. Ruggles practices as a consultant pharmacist, and monitoring those drug-gene interactions. So looking at the time of the PGX test and then following up at 30 and 60 days following the intervention of pharmacogenetic testing. And so we also wanted to look at the overall number of medications being prescribed. Does pharmacogenetic testing affect polypharmacy, as well as changes in pain scores and PHQ-9 scores for depression? We focused on those in the long-term care setting, 65 years old or more, with that polypharmacy mark of 5 or more medications. And so at the time the slides were due, we just got to the 60-day point. And so we haven't shared our data yet to have any statistical analysis done, but that is the next step. We were delayed a little bit like others in our study process, but we're excited to be at the point that we're at now, at least to even have some numbers to share with you. So at this point, I will turn it over to Dr. Ruggles, and she can talk about the results and sort of her process in working on this study.
Okay, can you hear me? Thank you, Dr. Petry. Yeah, I got the easy part. I just got to do kind of the testing and the med reviews, and I didn't have to do any of the back work on the grant, so I get to do what I love. So I'm the consultant pharmacist at a 250-bed long-term care facility in Bismarck, so we used that as our site for testing. When we looked through, we did not include those that were under 65 or those that did not have 5 or more medications, which was not many. And then also those that were currently in the hospital or those that were on a short-term stay of 30 days or less. And so we sent out about 140 letters to get consent. So patients had to consent to both the study and pharmacogenomic testing. And so we narrowed it down to 107 patients that were enrolled. And in the end, we got 99 that had results. We lost 3 to discharge, 1 expired. 3 refused to be swabbed the day of testing, and 1 had an insufficient sample. I actually did go back and re-swab her, but the second sample was also insufficient. For this, you can use a blood or a saliva sample for a pharmacogenomics test, and we opted to do the saliva sample just for the ease of patients. When we went into their rooms to swab them, many thought we were going to stick the swab up their nose and that it was going to be a COVID test, so they were pleasantly surprised it was a saliva sample. The average age of the patients tested was 82, 59 female and 40 male. And at the 60-day follow-up mark, we had 83 patients remaining. So we had some discharged, some in the hospital, but 83 remain. Of the 99 with results, so prior to testing, I did meet with, there's 5 providers that primarily round at this facility. So I met with each of the 5 providers, kind of let them know about our study, what it was for. Also gave some background on pharmacogenomic testing, how to use the results when they come back, and had a lot of good discussions. Of those 5 providers I met with, I would say 3 were optimistic and thought this was a really cool project to do. One was honest, and it was a mid-level practitioner that specializes in psychiatry. And she says, you can test, but I'm probably not going to make any changes based on the results. And then one provider was very excited, saying that this provider had done testing in their private practice before going to long-term care, was very excited about this project. Well, when I got the results back, I did go through each patient individually and made recommendations for each patient. So the pharmacogenomics report can be, a little bit tedious, 20 to 40 pages, depending on the genetics and gene-drug interactions. So I did for each patient break it down into a couple pages of recommendations showing significant interactions, making recommendations. I also looked at drug-drug interactions, phenoconversions, just polypharmacy and opportunities to deprescribe. So I did make recommendations for each patient. And so we did have 77 medication changes that were made. I was happy about this, but also wish there could have been more. The one provider I met with that was really excited about PGX testing that had done it in private practice made 0 changes. Every recommendation I sent out, the bottom said no changes and then sign their name. So that was frustrating. The one provider that said, you can test, but I'm not going to make any changes, ended up making quite a few changes, and in fact had called to see if I would come test patients at other long-term care facilities that she does rounds at. So that was encouraging. So the 77 medication changes that were made were encouraging. We had 4 severe gene-drug interactions. 2 of those were tramadol, a pain medication. 1 was clopidogrel, and 1 was simvastatin. Of those, we reduced it to 3. So the simvastatin was changed. Unfortunately, the provider that made no changes had the other 3 severe interactions. I did send the clopidogrel one to cardiology to follow up on. And so cardiology opted to keep the clopidogrel. Moderate gene-drug interactions were reduced from 64 to 32. So very encouraging reduction in those. And it would be nice to follow up longer than 60 days to see, did that correlate into decreased hospitalizations, decreased, side effects long-term, things like that. You'll see we do have a polypharmacy problem. The average number of medications at baseline was just about 21. This is all medications prescribed. So this is scheduled and PRN or as needed medications. In the future, I would like to just track scheduled medications, because when we were doing some deprescribing of maybe the muscle relaxers, proton pump inhibitors, some allergy meds, a lot of them were just changed from scheduled to as needed to see if the patients needed them or requested them. And so our data didn't change much, but in the future, I would like to track scheduled medications, because I do think that would have more accurately reflected some deprescribing opportunities. But you'll see at 60 days, it was about 20 medications, so not very significant. I don't have the statistics for you yet, but you can see it wasn't too much of a significant drop. Pain scores, pain does not seem to be a problem at this facility. The average was 1.798 at baseline. We did drop it though, pretty significant in the course of 60 days to a 0.422. I do attribute that to pharmacogenomics. There's a lot of tramadol and a lot of hydrocodone gene-drug interactions that we were able to address. So many people taking tramadol and hydrocodone for pain when it was likely ineffective due to metabolism. The PHQ-9 scores, of course, the lower the score, the less depression symptoms. And so we started out with a low score of 0.576, and we ended with nearly the same PHQ-9 score. There was a limitation there as well. In the long-term care setting, PHQ-9 scores are usually tracked about every 90 days for the MDS. So it was likely I was tracking the same score at baseline 30 and 60 days. And then also depression medications take a while to work. So it would be nice, to track this more long-term to see if things did change. So genetic variation, I'm always amazed at how much genetic variation there is in North Dakota, because you wouldn't think there would be. But looking at a couple of the CYP P450 enzymes, so these are enzymes that metabolize a majority of medications are these CYP enzymes, and we decided to track 3 of them. So CYP2C19, when I think of CYP2C19, I think of our proton pump inhibitors, your Nexium, your Prilosec, the medications for GERD or stomach acid. And so many of our older adults get put on those and then never taken off. And then also clopidogrel or Plavix, which is a medication used in cardiology, but it has to be converted to the active form in order to effectively work or work properly. And so look at the variation there of 99 patients, only 34 were normal metabolizers at CYP2C19. So we've got a lot of variation. 25 were intermediate or slower than normal. And then poor was 6 patients, which is the slowest metabolism. We had 30 rapid and 4 ultra rapid. So lots of interactions. When I looked at our top 6 drugs that had interactions, 2 of them were proton pump inhibitors. So pantoprazole and omeprazole, which maybe you think isn't a big deal. But when you look at it, if we're trying to heal an ulcer and they're an ultra rapid metabolizer, they're clearing that drug really fast. So it's important to switch to a more effective one. Also looking at patients who are on high dose proton pump inhibitors twice a day, we can oftentimes switch them to a more effective proton pump inhibitor at half the dose, dosed once a day, if they're on a more effective medication. And then of course we want Plavix or clopidogrel to be effective to prevent a cardiovascular event. CYP2C9, when I think of CYP2C9, I think of NSAIDs. Meloxicam is used a lot in long-term care, and celecoxib or Celebrex. I'm forgetting one. Fluvastatin. Fluvastatin is metabolized by CYP2C9. So looking at a lot of those medications, we had 61 of 99 with normal, 37 intermediate, and 1 poor. We do have a lot of older adults on meloxicam. They don't want to be on NSAID, but they have pain. So we did a lot of dose adjustments. With a lot of those NSAIDs, you can just reduce the dose. And so we did a lot of that. CYP2D6 is a big one. It's actually my favorite one because it's there's so much evidence in medications. I think of metoprolol, which is a beta blocker used in cardiology. That was our #1 gene-drug interaction in this study. Over 20 patients had a gene-drug interaction to metoprolol. What happens is if you're an intermediate or poor metabolizer, you break that medication down slower, and so you have a higher risk of a low heart rate, cold extremities, dizziness. I actually have a couple stories about metoprolol. One patient was switched to a different beta blocker, and this patient would get low blood pressure every afternoon. So she was on a medication to increase her blood pressure called midodrine. She was on metoprolol in the morning, but every afternoon she had to take midodrine to increase her blood pressure because it would drop. After switching beta blockers, she went off the midodrine. She no longer had those afternoon drops in blood pressure. Another patient reported at the 2-week follow-up switching to a different beta blocker. She's not dizzy anymore. So I think a lot of times with our older adults, they think some things are just normal. It's normal to be dizzy as I get older. It's normal to have cold hands and feet all the time. It's normal to have muscle pain. But once you do this and you can show them, you know, you're metabolizing this medication a little bit slower, are you having any of, you know, cold hands and feet, dizziness, then they'll be, oh, I didn't know that was a side effect. I just thought I was getting older. So it's nice to be able to prevent some of these side effects. And notice only 53 of 99 were normal at CYP2D6. Then we look at our transporters. The SLCO1B1 codes for the transporter that brings statins into the liver. ABCG2 takes rosuvastatin out of the liver. So if you have a decreased or poor function at SLCO1B1, it's harder to get the statin in the liver, and you can have a buildup of that medication, and it increases your risk for statin-associated musculoskeletal symptoms like muscle pain and other side effects. So we tracked these 2. You'll see only 66 were normal at SLCO1B1. I had a patient who was a poor metabolizer taking atorvastatin 80 milligrams a day. And I said, do you have any pain? He said, well, yeah, every day. Well, I said, well, why didn't you tell anyone? I thought it was a normal part of getting older. So we decreased him to a lower dose of a different statin, and he's doing so good. He said he has no more pain at all. So that's SLCO1B1. ABCG2 is for rosuvastatin specifically for guidelines. And so we'll see there only 80 of the 99 were normal. So in conclusion, our adverse drug reactions are a leading cause of death in the United States. When you look at the leading cause of death, they put accidental injuries in as number 3 behind cardiovascular disease and cancer. Actually, adverse drug reactions alone could be number 3. And I wish they would just say it because people need to be aware of what a problem it is in the United States. Pharmacogenomics is a useful tool to detect gene-drug interactions. And in this pilot study, pharmacogenomics guided interventions reduced gene-drug interactions by nearly 50%. So like I say, it would be nice to track that long-term to see how many hospitalizations and side effects we could prevent. The long-term care population is an understudied group for PGX research despite wide genetic variation. We've seen there's lots of variation. And the long-term care population is such a great population of people to study because there's so much polypharmacy or prescribing for side effects of medications, and we have an increased risk of cognitive impairment. So if they're having a side effect, maybe they can't tell you, but then when you look at the pharmacogenomics report, you can see they're at high risk for this side effect, or it's a high probability this medication isn't working, and make some adjustments for those patients who can't verbalize what they're feeling. Further research should investigate long-term implications of medications, pain, and depression scores. So that's our presentation. Special thank you to everyone from the TRANSCEND team. We so appreciate it. And then our team that has helped so much with this project. Go ahead.
It's really, as a practitioner, I have the same experience that you mentioned, that some patients are on 20 medication.
Yeah.
I saw a patient this year on 42 medication. Definitely put in elements. So the interaction of the drug, genetic profile is really important. But then when you start to add multiple medications, it starts to be one of the things. And I think you alluded to that. There are the drug-drug interactions, there are the toxicities, the changing metabolism over time. There's the evolution of the disease. And so how would you frame this pharmacogenomics in terms of the greater kind of sphere of problems that the pharmacist and the physician have to face? I always feel like you should treat the person with the minimal number of medicines to get by. How do we get there?
Yeah, that's a great question. I just gave a presentation on deprescribing and long-term care. And I think the best way for us to get there for less medications is in our older adults to assume every new disease is a side effect. First, assume it's a side effect of a medication. Oh, you've got fluid retention or edema. Let's first look, is it a side effect of a medication or is it a new problem? Likely when you're on 20 plus medications, it's a side effect. So instead of prescribing a diuretic to treat the edema, let's just switch blood pressure meds that don't cause edema. So looking at trying to stop that prescribing cascade and I was educating the nurses in long-term care facilities when they identify a new problem and they send a fax or a note to the provider, end with the question, could this be from a medication? So at least it gets everyone thinking, maybe this is a side effect instead of a new problem. And then we can look at our pharmacogenomics report to help. Yes, absolutely. Yeah, I'll send it to you. Yeah.
Well, we have very little data on medication efficacy in older people. And certainly the likelihood of the risk-benefit ratio being good in older people gets smaller. Right? The average 80-year-old is going to live to 88, 86, 87, something. So the likelihood that you're going to change their mortality with most of these medications is probably pretty small. And the risk-benefit is definitely different than when you were 50. So I think we ought to start really looking at, are any of these medications actually doing anybody? So for example, the American College of Cardiology and AHA stopped recommending use of statins in older people because there's no data that they're actually going to have life prolongation. So I could, I mean, the whole concept of taking 20 medicines a day, it's totally unrealistic.
Oh yeah, and it happens every day. Yeah.
Likely to be marginal value. But I think we need to start thinking about that very carefully what is the value of doing these things at these age ranges. For example, TAVR, which we heard earlier. The life expectancy after TAVR is not very good. And it's not because they now have acute aortic stenosis, which is bad for them. We fixed that. They just have other stuff that's bad for them that they die from, that we didn't bother to think about. So I think we need to have sort of new thinking about the risk-benefit ratio as a function of time, as a function of age.
Right. Yeah. I mean, even we know some medications increase your risk for dementia by 46% if you take them for 6 years or longer. Even looking at anticholinergic burden scores that would be another fun project to see. But
well, likely, for example, beta blockers have no benefit after a year after acute coronary syndrome. So why do we do it for?
right. Yes.
I was really surprised. First of all, this was really a huge eye opener for me because I'm an epidemiologist, and that's why I was surprised when you mentioned that it's among the top 5 causes of death. Because if you go to the CDC, it's not there. And my question is, well, why is it there? But yes, if you pick your authorities, so if you go to the American Society of Pharmacovigilance, which I'm sure we're all members of, it's number 3. But it's number 3 because it includes accidental overdoses, which I don't really think of as a drug-drug interaction. I think that is sort of a drug action, not interaction. If you take too much heroin, your breathing was compromised. So I'm curious. First of all, this is just so new to me and so interesting. I wonder where drug interactions as a cause of death rank if you take out accidental overdoses.
They do have some data on that website. You can go look at their methods for reporting adverse drug events. And it is interesting if you go read through it. Even like medication errors, are included in that, which could happen in the home, in a hospital, in a long-term care facility. But there's more information on that website that's very good.
Sort of a scientific question as opposed to medical questions. It's sort of an established fact that as people age, their epigenetic regulation goes down. For example, DNA tends to get methylated over time, which would have the effect of reducing the activity of many of these enzymes that you're looking at. Have you considered looking at the epigenetics of your patients?
That would be a Dr. Petry question.
No, we have not. There's lots to explore in this area. That's not any that we've looked at closely yet.
The problem is that epigenetics doesn't change at a constant rate. So you could have patients who are 80 years old and have the epigenetics of a 50-year-old, or you could have some, the opposite. So it will be layered on top of the genetic variation, but it would add another degree of difficulty to try to be predicted.
So these pharmacogenetics been around for a while, and we every now and then we prescribe and we see an alert on Epic of somebody had that you cannot done. My question is a practical one. This is very interesting work, and some of this is already known too. Why don't we run these on everyone? I treat a lot of ulcers, give people omeprazole the first time. Bariatric patients are not absorbing very well, and activation is not great already. So it doesn't make sense to, is it a funding issue from insurance companies or payers, or does it make sense for us to just give everybody lansoprazole or esomeprazole off the bat?
Yeah, I think that's esomeprazole, off the bat if you don't have a test. But Medicare will cover a pharmacogenomics test once in a lifetime with a qualifying medication and diagnosis, which is how most of our patients were funded. Advantage plans are different. They probably have a copay. Commercial insurance is difficult, and North Dakota Medicaid won't cover them. So that's the barrier, is it getting insurances to cover these tests. So, but yes, we believe everyone should have a test done. Thank you.
Yeah, the financial piece is a huge barrier in insurance not covering. And then sort of the portability of results in that, like if you practice at Sanford, it's built into the EMR and the alerts fire. But if you get an external test and you just have a piece of paper or PDF, it's not as, interactive. And how can, if a patient brings it to their physician and says, here you go, and the physician hasn't been trained on it and doesn't have time, how useful can that information be in real time? So there's some issues there, I think, as well, that are established barriers in the field. If you can get formulary to cover it.